Good evening, Dr. Phil here. Today we'll be discussing on nerve injuries in the perioperative setting. Topic outline. We will be discussing how is the anatomy of the peripheral nerve relevant to perioperative nerve injury associated with peripheral nerve blocks. We will be discussing on what is the pathophysiology of perioperative peripheral nerve injury, the risk of adverse outcomes associated with nerve blocks, the causes and risk factors of perioperative peripheral nerve injury, the ways to reduce the risk of nerve injury during peripheral nerve blocks, the barriers impeding accurate and timely diagnosis of perioperative nerve injuries, how to diagnose and manage patients with neurological deficits after nerve blocks, and how to prevent infections associated with central neuraxial blockade. How is the anatomy of the peripheral nerve relevant to perioperative nerve injury associated with peripheral nerve blocks? Neurons are nerve cells composed of a cell body, dendrites and axon. The axon is a cytoplasmic extension of the neuron and transmits electrical signals along its length. Myelinated axons are characterized by a sheath of Schwann cells that encase the axon in a layer of myelin. Schwann cells are interrupted at nodes of Ranvier, where depolarization and repolarization occurs during saltatory propagation of action potentials. The nerve fiber consists of axon, myelin sheath, and endoneurium, and are organized into groups called fascicles. The nerve is an organ comprising of neural tissue, a specific connective tissue stroma, and a designated blood supply. Peripheral nerves are structures consisting of numerous fascicles held together by the epineurium. The endoneurium is a layer of connective tissue that surrounds axons. Non-fenestrated capillary blood vessels are embedded in the endoneurium, which is part of a protective barrier against chemical and mechanical injury. The perineurium is multi-layered, 8 to 18 cell epithelial sheath surrounding each fascicle. Tight junctions exist between perineural cells, which form a part of a protective barrier against chemical and mechanical injury. Nerve fibers form an intraneural plexus, where axons take different positions along their path within each fascicle. The space between perineural cells is composed of fundamental amorphous substances, collagen fibers, and fibroblasts. The epineurium consists of collagenous tissue on the outer surface of the nerve. It is highly compliant and permeable. It is the thickest of the three connective tissue layers. The epineurium encases groups of fascicles along with their interfascicular supporting tissue and adipocytes. Interfascicular tissue embeds the fascicles and contains adipose tissue, blood vessels, and lymphatics. The vasa nervorum is the blood supply to the peripheral nerves, consists of extrinsic and intrinsic supply. The extrinsic supply consists of arteries, arterioles, and veins which lie within the epineurium. The intrinsic supply consists of non-fenestrated capillary blood vessels embedded in the endoneurium. Anastomosis between the two vascular systems is formed by vessels that originate in the epineurium and traverse the perineurium. Variation of contents. In the nerve roots, there is reduced tensile strength and reduced elasticity when compared to axons and their supporting elements in the peripheral nerve trunks. Axons in spinal nerve roots are not surrounded by a perineurium or structures with a barrier effect. The size and number of fascicles in a peripheral nerve vary from one nerve to another. There is increased proportion of connective tissue occupying the cross-sectional area of a nerve as the nerve travels distally away from the neuraxis. The exact location of the needle tip determines the likelihood of neurological injury associated with peripheral nerve blocks. An extraneural injection is an injection that takes place outside the epineurium. An intraneural injection is an injection that takes place inside the epineurium, which can be extrafascicular or intrafascicular. An extrafascicular injection is an injection that takes place outside the nerve fascicle. The perineurium is not breached. An extrafascicular injection is less likely to result in nerve injury. However, the anesthetist should not purposefully seek needle-to-nerve contact or intentional intraneural injection. Intrafascicular injection occurs when the injection takes place inside the nerve vesicle. The perineurium is breached. The protective environment of the vesicles is exposed to insults. Solutions injected intravascularly results in axonal degeneration and permanent neural damage. Accidental intraneural injections often do not result in intravascular needle placement due to the needle deflection away by the tough perineurium. Injury to the vasa nervorum can lead to ischemia and inflammation due to hematoma formation. What is the pathophysiology of perioperative peripheral nerve injury? Mechanisms of PNI can be mechanical, vascular, or chemical injury. Examples of mechanical or traumatic injury includes compression, for example, by forceful needle to nerve contact, compression from tourniquets, chronic extrinsic compression of nerves, for example by fibrous bands or scar tissue, which results in entrapment neuropathies, and compression by hematoma or abscesses. Stretch injury. Nerves or plexi are stretched when they are placed in non-physiologic or exaggerated physiologic positions. Nerve laceration can occur by needle trauma, cautery, or other mechanical insults. Injection injury occurs when intraneural injection of LA occurs in a confined space. This increases intraneural pressures, which may exceed capillary occlusion pressures, resulting in nerve ischemia. Vascular or ischemic injury. Direct trauma to nerve vasculature may result in nerve ischemia. Occlusion of the vasa nervorum, for example, by hematomas, LA, adrenaline or other adjuncts, high injection pressures, or tourniquets reduce neural blood flow and causes nerve ischemia. Vascular thromboembolism can also cause ischemic injury. Chemical or neurotoxic injury can be caused by various chemicals such as chlorhexidine, alcohol, local anesthetic, LA adjuvants such as adrenaline, ketamine, and midazolam, ultrasound gel, phenol, iodine, antibiotics, steroids, bovine collagen, botulinum toxin, inflammatory reaction, etc. Regarding LA, almost all LA can have myotoxic, neurotoxic, and cytotoxic effects in various tissues under certain conditions. LA can cause fragmentation of DNA and disruption of membrane potential in mitochondria, resulting in uncoupling of oxidative phosphorylation and apoptosis. Neurotoxicity by LA increases with increased duration of exposure, high concentration of LA, intravascular LA injection, type of agent. Ester LAs are more neurotoxic than amide LAs, ropivacaine being the least neurotoxic LA, and increased LA-mediated vasoconstriction may result in reduced blood flow and nerve ischemia. In descending order of degree of vasoconstriction caused by LA, levobupivacaine has higher vasoconstrictive properties, followed by ropivacaine and lidocaine. The severity of peripheral nerve injuries can be classified according to Seddon's classification or Sunderland's classification. For neuropraxia, which corresponds to Sunderland 1, myelin damage occurs, which is typically caused by nerve stretching or compression. The endoneurium, perineurium, and epineurium are intact. Electrophysiology shows conduction slowing and blocking. Prognosis is good. Complete recovery of function can occur within weeks to months. Most neurological injuries following regional anesthesia tend to be neuropraxic in nature. The next Seddon classification is axonomesis, which corresponds to Sunderland 2. There is loss of axonal continuity. Mechanisms includes vesicular impalement, nerve crush or toxic injury. The endoneurium is intact. NCS shows low amplitude or absent motor and sensory responses, and EMG shows denervation. Prognosis is fair, recovery is prolonged and variable. The next Seddon classification is neurotmesis, which corresponds to Sunderland 3, 4, and 5. In Sunderland 3, there is loss of axonal and endoneural continuity. Perineurium is intact. Electrophysiology is similar to axonomesis with no re-innervation on serial studies. For Sunderland 4, there is loss of axonal, endoneural, and perineural continuity. Epineurium is intact. Electrophysiology is similar to axonomesis with no re-innervation on serial studies. For Sunderland 5, there is complete nerve transaction. Electrophysiology is similar to axonotmesis, with no re-innovation on serial studies. For neurotmesis, the prognosis is poor. What are the risks of adverse outcomes associated with nerve blocks? Peripheral nerve blocks. Regarding peripheral nerve injury, the precise incidence is difficult to ascertain due to its rare occurrence, and the methods and qualities of studies varies. For post-operative neurological symptoms, such as paresthesia or numbness, this can occur in up to 15% of cases. However, it rarely results in permanent injury. Incidence significantly reduces over time, with 0 to 2.2% at 3 months, 0 to 0.8% at 6 months, and 0 to 0.2% at 1 year. Post-operative permanent nerve injury after peripheral nerve block is 0.014 to 0.04%. This figure is likely to be higher in certain groups of patients. For comparison purposes, minor short-term nerve damage after GA occurs in 1% of patients. Peripheral nerve injury after GA lasting more than 3 months, 0.05%, and lasting more than 1 year, 0.02%. Infections associated with peripheral nerve block ranges from 0 to 8.8%. Peripheral hematoma after PNB is exceedingly rare, with less than 30 cases reported in literature. Systemic LA toxicity after regional blocks occurs in 1 in 1,000 patients. For eye blocks, transient ptosis after eye block, 1 in 2 at 24 hours and 1 in 5 at 1 month. Transient diplopia after eye block, 1 in 4. Brainstem anesthesia following ophthalmic block, 1 in 700. Retrobulbar hemorrhage following eye block, 1 in 5,000. Neuraxial blocks. Severe headache following epidural, 1 in 100. Following spinal, 1 in 500. Neurological deficits. Urinary dysfunction after spinal or epidural, 1 in 50. Cranial nerve palsies after spinal, 1 in 50,000. Permanent nerve damage after epidural or spinal ranges from 1 in 23,500 to 1 in 50,000. Paraplegia or death after epidural or spinal ranges from 1 in 54,000 to 1 in 141,000. Paraplegia after spinal or epidural in obstetrics, 1 in 250,000. Infections. The reported rates depends on the study. For spinal or epidural abscesses, the range is 1 in 40,000 to 1 in 100,000 of neuraxial anesthetics. For epidural, analgesia or anesthesia, rates of superficial infection ranges from 1 in 50 to 1 in 8. Rates of deep infection can be up to 1 in 150. Epidural abscess post-epidural insertion in obstetric patients, 1 in 500,000. Meningitis post-epidural insertion in obstetrics, 1 in 100,000. Epidural catheters inserted for long-term pain control become infected more frequently than those used for short periods of time. For subarachnoid analgesia or anesthesia, infection rates is 3.5 patients in 100,000. Examples of infections include meningitis, epidural abscesses, soft tissue abscesses, infections of a disc or of a disc space, cerebral and spinal abscesses, and necrotizing fasciitis. Hematoma. For symptomatic spinal epidural hematoma, overall 1 in 150,000 for epidural and 1 in 220,000 for spinal. The rate for SEH can be as high as 1 in 1,000 in elderly women undergoing lower extremity surgery. For cranial subdural hematoma after spinal, the rate is 1 in 500,000. For spontaneous epidural hematoma, the rate is 1 in 1 million. What are the causes or risk factors of perioperative peripheral nerve injury? This includes surgical factors, anesthetic factors, and patient factors. Surgical factors. Peripheral nerve injury is 9 times more likely to be a result of factors related to surgery or the patient rather than related to a nerve block. PNI is associated with certain types of surgery, general anesthesia, hypertension, and smoking, but not peripheral nerve blocks. Incidence of neurological complications associated with different types of surgery. Overall incidence of PNI, 0.03%. Neurosurgical surgery, 0.07%. cardiac surgery 0.077%, general surgery 0.05%, orthopedic surgery depends on the type of surgery and ranges from 0.1% to 77%. Mechanisms of direct or indirect nerve injury includes traction, stretch, compression, ischemia, contusion, dissection, electrocautery thermal injury, etc. Intra-op factors causing PNI includes patient malpositioning, for example, peroneal compressive neuropathy at the fibular head, compression of ulnar nerve at the cubital tunnel, lateral tilting of the head causing brachial plexus stretch injury, prolonged lithotomy position causing femoral nerve compression, sitting position causing sciatic nerve neuropraxia, etc. Tourniquet use. Tourniquet causes physical compression, mechanical deformation, and nerve ischemia. Long tourniquet time and high inflation pressures worsens PNI. Methods to reduce tourniquet neuropathy includes usage of wide contoured tourniquets, use of lower cuff pressures, and limitation of the duration of inflation. Other intra-op factors includes fixators, sharp instrumentation, and electrocautery. Post-op factors contributing to PNIs includes patient malpositioning, prolonged immobilization, immobilization devices such as casts and braces, edema of an extremity within an immobilizing device, and post-surgical inflammatory neuropathy. Anesthetic factors. Peripheral nerve blocks. Intravascular high-pressure injections are linked to peripheral nerve injury. However, some large studies have failed to link PNB as an independent risk factor for PNI. Determining causation in the setting of surgery and RA can be challenging as these factors are often confounding. Peripheral nerve blocks can cause nerve injury by mechanical, vascular, or chemical mechanisms. Mechanical injury can be caused by needle trauma, catheter trauma, intravascular injection, PNB injections at more proximal sites, hematoma, abscess, and compression or stretching of nerves due to the insensate limb. Vascular injury can be caused by trauma, occlusion of vasa nervorum, for example, by hematomas, LA adjuncts, and high injection pressures, and vascular thromboembolism. Chemical injury to nerves can be caused by chlorhexidine, alcohol, inflammation, LA, etc. Sedation or general anesthesia can contribute to formation of PNIs. The sedated or unconscious patient have reduced ability to report symptoms that may indicate mechanical trauma to nerves. Patient factors. Pre-existing neuropathy, smoking, hypertension, BMI extremes, the elderly, peripheral vascular disease, prolonged hospitalization, electrolyte imbalances, infections, anticoagulant therapy, vascular injury, vasculitis, and hematoma contributes to occurrence of perioperative nerve injury. Regarding pre-existing neuropathy, the double crush theory states that patients with pre-existing neurological conditions are susceptible to subsequent nerve injury from a secondary insult at a site remote to the original neurological dysfunction. Peripheral neuropathies also impair the potential for recovery following a PNI. 4 patterns of peripheral neuropathy includes polyneuropathy, mononeuropathy, mononeuritis complex, and autonomic neuropathy. Examples of neuropathies includes central pain syndrome such as multiple sclerosis, post-stroke pain, spinal cord injury and spinal stenosis, and peripheral pain syndromes such as hereditary neuropathies, metabolic neuropathies such as diabetic polyneuropathy. Diabetic neuropathy may increase the risk of nerve damage by more than 10 times. Iatrogenic or toxin-induced neuropathies such as due to chemotherapy or alcohol, infectious neuropathies, immune-mediated neuropathies such as Guillain-Barré syndrome, entrapment neuropathies, and those caused by trauma. What are the ways to reduce the risk of nerve injury during peripheral nerve blocks? The etiology of PNB-related neurological complications is multifactorial. The above-mentioned risk factors should be addressed appropriately to reduce the risk of neurological complications. For patient factors, avoid PNB in patients with contraindications for PNB. Absolute contraindications includes patient refusal, infection over needle puncture site, and LA allergy. Relative contraindications includes peripheral neuropathy, coagulopathy, and uncooperative patients. Regarding peripheral neuropathy, neuropathic nerves are vulnerable to dysfunction after insults such as PNB based on the double crush phenomenon. No absolute method exists for predicting how a patient with a pre-existing neuropathy will fare with a regional block technique. The decision to proceed with regional anesthesia in these patients should be made on a case-by-case basis. Consider risk of nerve injury when balancing the risk and benefit of a PNB. The most conservative legal approach is to avoid regional anesthesia in patients with pre-existing neuropathy. Full appraisal of the risks and benefits associated with regional anesthesia and alternatives to regional anesthesia should be presented to the patient. Advising patients of the risk of post-procedural neuropathy reduces the likelihood of misunderstanding and resentment if an unexpected unwanted event occurs. Documentation and comprehensive evaluation prior to regional anesthesia demonstrates that an attempt was made to identify potential pitfalls. If PNB is undertaken, use ultrasound to maintain a distance between the needle and the nerve in order to minimize the risk of perioperative nerve injury. Use the lowest concentration and dose of LA possible and avoid adrenaline. Performance of peripheral nerve blocks in the awake or asleep patient. Presence or absence of paresthesia or pain during needle positioning or during injection of LA does not predict nerve injury reliably. However, paresthesia or pain during needle positioning or during injection may be an important warning sign for possible intraneural needle tip placement, and injection should be stopped if the patient complains of severe pain during needle advancement or injection of LA. PNBs are performed under GA under certain conditions, for example, in patients at risk of movement during the nerve block. In anesthetized patients, signs of pain includes limb movement, laryngospasm, sympathetic response such as tachypnea, tachycardia, and hypertension. The injection should be stopped if these are present and the needle repositioned. Nerve blocks in awake, responsive adults allows for symptoms of local anesthetic systemic toxicity to be reported. Anesthetic factors. Ensure that the person performing the nerve block is adequately trained to perform nerve block safely. PNB selection. Consider PNB in patients only when its benefits outweigh the risk. For example, avoidance of GA in poor health to avoid post-op nausea vomiting or desire for early discharge from the hospital, desire to avoid sympathetic block of Neuraxial techniques, faster emergence and recovery, early return to normal diet especially in diabetics, post-op analgesia, improvement of blood supply to surgical area, improved rehabilitation, and for early mobilization of operative area. Choose the appropriate PNB for the surgery or indication. Confirm the site and site of the nerve block to be performed. If the surgery can be done under a distal nerve block, do not perform a more proximal nerve block. Use appropriate aseptic measures to reduce the risk of infections. Avoid excessive needle passes or injections. Equipment-related factors. Needle design. Sharp, long-beveled 12 to 15 degree needles are more likely to pierce the perineurium to cause fascicular injury, particularly when the bevel is transversely oriented to the nerve fibers. However, if the nerve or fascicle is penetrated by a sharp needle, there is less injury due to the clean cut produced. For blunt, short-beveled needles, 45 degrees, these are non-cutting and are less likely to pierce the perineurium and may allow fascicles to slide away from the needle, potentially reducing neural injury. However, if a short-beveled needle penetrates the perineurium, the extent of mechanical trauma is far worse than that produced by a long-beveled needle. There is increased appreciation of fascial planes with blunt, short-beveled needles compared to long-beveled needles, but fascial puncture requires increased applied pressure, and the needle can overshoot after puncturing the fascia, potentially damaging structures beneath the fascia. Needle diameter. A thicker needle can cause increased fascicular damage and increased risk of tissue injury or hematoma compared to a thinner needle. Needle length. The choice of needle length depends on the depth of the target nerve to be blocked. Ultrasound can help with determining the distance to the nerve and the needle length required. Choose the correct length. If the needle is too short, the needle is unable to reach the target nerve. If the needle is too long, it is difficult to maneuver and may advance too deeply and risk tissue damage. Depth markings help with monitoring the depth of penetration. Local anesthetics and adjuvants. All LA are potentially neurotoxic as mentioned previously, with certain adjuvants such as adrenaline, ketamine, and midazolam being potentially neurotoxic. Non-neurotoxic adjuvants includes opioids, clonidine, dexamethasone, and neostigmine. Dexmedetomidine has been shown to be neuroprotective. None of these adjuvant agents are licensed for perineural injection. Nerve localization techniques aims to reduce the risk of intraneural or intravascular LA injection. However, no human study to date clearly demonstrates an advantage of one nerve localization technique compared with another to reduce peripheral nerve injury. Triple monitoring, consisting nerve stimulation, ultrasound, and pressure monitoring, has been suggested to be of benefit in reducing PNI, although evidence is lacking. Paresthesia is unreliable as an indicator for nerve-to-needle contact. Peripheral nerve stimulation, motor response with a current intensity of 0.2 to 0.5 milliamps with a pulse duration of 0.1 millisecond, is suggested by many authors that needle-to-nerve position is sufficient for accurate and safe placement of LA. Motor response at a current of less than 0.2 MA is highly specific for intraneural needle placement. However, it is not sensitive in predicting intraneural needle placement, as a current of more than 1 MA can still be required to elicit a motor response after intraneural needle placement. The needle should be repositioned if motor response is seen at less than 0.2 MA. However, nerve puncture and mechanical injury may have already occurred. Needle repositioning prevents further pressure or chemical damage during LA injection. Electrical peripheral nerve stimulation does not predict needle tip to nerve location accurately. In a study by Perlas A. et al., no motor response was generated 25% of the time with a current of 0.5 MA or less when the needle tip was indenting the surface of a nerve under ultrasound guidance. Failure rate of PNBs using PNS for nerve location ranges from 5 to 50%. Electrical impedance. There is a clear difference in impedance between extraneural and intraneural compartments, which can be measured. However, nerve puncture must first occur to detect an impedance change. There is no defined absolute impedance value for intraneural needle placement, and this is not widely used at present. Ultrasonography. Advantages during PNB includes it enables visualization of spread of injectate. It helps reduce the dose and volume of required LA. It reduces the incidence of LA systemic toxicity. It reduces the incidence of intravascular puncture. And ultrasound can help detect nerve swelling, which should prompt cessation of injection. Limitations of ultrasound during PNBs. There is lack of evidence that ultrasound influences the risk of long-term PNIs. Detection of intraneural injection by ultrasound imaging may be too late, as injection of only a small quantity of injectate can rupture a fascicle. Current ultrasound technology is unable to provide adequate resolution to differentiate interfascicular and intravascular needle placement or injection. Adequate imaging of needle-nerve interface is affected by operator skill and patient anatomy. Various strategies have been developed to enable reliable visualization of the needle tip under ultrasound to reduce the risk of intraneural injection. For example, echogenic needles increases the visibility of the needle during ultrasound-guided PNB by increasing the reflection of ultrasound beams. Needle beam angle should be more than 55 degrees. Needle bevel opening should be oriented to face the ultrasound beam directly. or face 180 degrees away from the beam. Needle diameter. A larger diameter needle increases visualization, but at the expense of increased tissue and neural trauma and increased discomfort. Hydrolocation. A small volume of injected acts as a surrogate marker of needle tip position and aids in opening up the space between structures. And ultrasound technology such as electronic needle tracking, compound imaging, electronic beam steering, and color Doppler detection of the tip by the color mark device. Injection pressure monitoring. Subjective assessment of injection pressure by the syringe feel technique is highly inaccurate. Objective assessment of injection pressures can be made by using commercially available devices such as this inline pressure monitoring device, or by the compressed air injection technique developed by Sui. Objective assessment of injection pressure is highly sensitive for intravascular intraneural injection but lacks specificity. A low opening injection pressure of less than 15 psi indicates either extraneural injection or intraneural extravascular injection. No case reports of clinically significant nerve injury have been reported with low opening injection pressures. High opening injection pressure of 15 psi or more may indicate intravascular injection. However, high initial pressures can be followed by a drop in pressure after fascicular rupture. Other causes of high opening injection pressure includes needle to nerve or needle to tendon contact, needle obstruction, or tissue being compressed by an ultrasound probe. Reposition the needle if opening injection pressure is more than 15 psi. Next, we move on to the barriers impeding accurate and timely diagnosis of perioperative nerve injuries, which includes lack of recognition or documentation of pre-existing neurologic disease, pre-existing neuropathy, explain falsely localizing neurologic signs discovered during the assessment of an apparent post-operative nerve injury, delayed recognition of neurologic deficits. Neurological symptoms and signs may be masked by analgesics, pain, sedation, dressings, casts, activity restrictions, and drains. Presumption by the patient that abnormal neurological symptoms that they experience are normal post-op symptoms may cause them not to complain to their physician regarding their symptoms. PNI in ambulatory patients who are not followed up properly causes a delay in reporting of symptoms. Sometimes the clinician presumes that the patient's symptoms are due to the nerve block, which in fact they may be distinct in distribution from the expected neurologic deficit. Inaccurate history provided by the patient regarding their symptoms may impede accurate and timely diagnosis of PNIs. Patients often see the post-op period as a single time epoch instead of individual days. Precise recognition of symptom onset is useful in narrowing down the differential diagnosis causing PNIs. Late onset symptoms often have non-anesthetic or operative related causes such as immobilization or compression in the recovery period, infection, and post-op inflammation. Miscommunication between the anesthetist, surgical team, and the neurologist. Most neurologists are unfamiliar with the operation room, regional anesthetic technique, and surgical approaches to various problems. Neurologists may be unable to arrive at an accurate diagnosis as they are unaware of which structures were most at risk or which mechanism of injury may be most probable from a given surgical or anesthetic technique. Anesthetic or surgical records may be unavailable, inadequate, or formatted in a way that is difficult for non-anesthetists to extract useful diagnostic information. How to diagnose and manage patients with neurological deficits after peripheral nerve blocks. RA societies such as RA UK and ASRA have published algorithms to assist clinicians to manage perioperative nerve injuries. And here is one example. Perioperative nerve injury is suspected if there is new onset of pain, weakness, numbness, paresthesia, or abnormal sensation, and effects of nerve block last beyond the usual duration of the nerve block. Review relevant medical or surgical history, surgical or anesthetic records, drug chart, and observation charts. Clinical examination, including neurological examination by the surgeon. If there are mild or resolving symptoms or persistent sensory deficits, reassure the patient and review in 4 weeks. If there are no persistent symptoms, no further follow-up is required. If there are persistent symptoms, refer neurologist and consider MRI, other imaging, nerve conduction studies, and electromyography to arrive to a definitive diagnosis. Treatment options include conservative, such as drugs and physiotherapy, and surgery. Follow up as appropriate and keep the patient and responsible team informed. If there are complete or progressive neurological deficit or presence of motor deficit, inform the responsible surgical, anesthetic team, and acute pain service team if indicated. Immediate neurology consultation. Consider imaging studies, nerve conduction studies, and electromyography. In case of suspected space-occupying lesion associated with central neuraxial blocks, treat as emergency and follow local guidelines. Diagnose treatable causes such as hematoma, nerve cut, compartment syndrome, and abscesses, and administer appropriate intervention. Treatment options include conservative or surgical, as mentioned. Follow up as appropriate. Additional notes for diagnosing suspected perioperative nerve injury. Diagnosis is based on history, physical examination, and investigation results to afford patients the best chance of neurological recovery if nerve injury occurs. Aim for early recognition of nerve injury and risk stratification to prioritize those that require urgent attention and those that do not. Symptoms of nerve injury, such as tingling, numbness, paresthesia, pain, sensory loss, and motor weakness, varies depending on the origin and severity of the injury. Presentation may be acute or delayed. Signs of nerve injury, for example, sensory loss, motor weakness, or abnormal sensations. Signs of suggestive cause, such as ongoing LA effects. Bruise may indicate hematoma or site of compression. Fever, swelling, erythema, or tenderness may indicate infection, trauma, or neurotoxic injected. Pallor, loss of pulse, and CRT more than 2 seconds may indicate ischemia. Immobilization devices may cause nerve compression or nerve stretch, as do malpositioning. Single or multiple nerves may be affected. Assess and document motor and sensory impairments, as this determines prognosis. Pure sensory deficits occurring within the territory of the peripheral nerve block often resolve within days to weeks. Motor deficits are generally a more ominous sign. Diagnostic tests. Neurophysiological studies consist of EMG or NCS or both. Timing of these tests. When performed acutely, EMG and NCS may help confirm neuropraxia with conduction block or defined pre-existing disease. When performed 3 weeks after the injury, axonal loss, which is prognostic, and the extent of a perioperative neurogenic injury will be better clarified by electrodiagnostic studies performed 3 weeks after the injury to allow for sufficient signs of Wallerian degeneration to appear. EMG is an electrophysiologic test whereby a small, commonly 26-gauge concentric recording needle is placed into muscles innervated by different spinal roots, pathways through the plexus, and peripheral nerves to identify characteristic electrical changes of neurogenic disorders, myopathic disorders, and neuromuscular transmission disorders. EMG examines the electrical activity generated within a muscle and determines the muscle units affected by the injury, the site of a nerve injury, the severity of the injury, and whether recovery is occurring. NCS is an electrophysiologic test whereby a peripheral motor, sensory, or mixed sensory motor nerve is stimulated and a recording made of the motor or sensory response. It assesses the electrical conduction of impulses along a nerve. A characteristic waveform of nerve conduction velocity is produced. Normal values have been established using standard techniques. NCS can locate the site of conduction block and may confirm or refute that the PNI lesion is at the site of the peripheral nerve block. NCS can be used in the acute perioperative period to identify patients with a common compression neuropathy by identifying conduction block at a common site of compression. NCS may be unable to distinguish between anesthesia and surgery-related causes when the surgical incision site, block site, and tourniquet are in close proximity. NCS offers prognostic information depending on the degree of injury found on examination, which may be neuropraxia, axonotmesis, or neurotmesis. Imaging studies. Urgent imaging such as CT or ultrasound should be pursued if a bleeding complication is suspected. For example, when perioperative interventions are performed or maintained while the patient was on anticoagulation, antiplatelet agent, has thrombocytopenia or bleeding diathesis, or when perioperative procedure is performed in close proximity to vascular structures, especially when regional anesthesia was performed without ultrasound guidance. Additional notes for managing suspected PNIs. Consultations. Early consultations are essential to allow identification of potentially reversible factors such as tight cast or dressing, compartment syndrome, hematoma, occult perineural microhematoma, and post-surgical inflammatory neuropathy. Examples of consultations include surgical, neurological, and radiology. Cases with severe neurologic deficits and a concern for a potential surgical complication, for example, PNI due to sutures, clips, instrumentation, trauma, transaction, or traction, may require urgent surgical exploration. Neurological consultation and radiological imaging is recommended if examination reveals motor weakness, when there is difficulty in localizing or reconciling the injury with the expected distribution of the nerve block, surgery, or region of common nerve compression, when there is complete absence of nerve function beyond the duration of the peripheral nerve block, nerve injuries with moderate or severe functional limitations, progressive neurological deficit, symptoms fail to progressively improve, or in severe pain. Referral to a specialist peripheral nerve surgeon should be considered if there is incomplete or no improvement of neurological symptoms by 3 to 5 months. Non-surgical interventions includes pharmacological or physical therapy. No pharmacological therapy has been demonstrated to enhance neuroregeneration. Neuropathic agents and non-narcotic analgesics may be prescribed for neuropathic pain. Physical therapy is used to maintain muscle mass and prevent contractures. Post-surgical inflammatory neuropathy arises from an inflammatory immune response triggered by the stressor of surgery or anesthesia that inappropriately targets the peripheral nervous system. Nerve biopsy shows perivascular lymphocytic inflammation consistent with a microvasculitis with significant axonal loss. This condition may present as atypical unexplained refractory post-op pain, severe limb pain, and emerging neurologic dysfunction after a period of documented return to baseline neurologic function post-op, multifocal or difficult to localize progressive post-op neurologic deficits. Early neurologic consultation is indicated. Corticosteroids are often used to treat this condition, but they have not been evaluated in RCTs. Peripheral hematoma after PNB. Hematoma may occur in the periphery after single-shot or continuous nerve blocks, but is exceedingly rare. Risk factors include procedural difficulty and concomitant anticoagulation or antiplatelet therapy. The patient may present with bruising, tenderness, hypotension, reduced hematocrit or hemoglobin, hemorrhagic shock and death, and rarely neurologic dysfunction. If neurologic dysfunction is present, all are resolved by 1 year in all case reports. Prevention. Due to the rare nature of this complication, it is difficult for experts to make recommendations regarding this procedure in the setting of anticoagulation. Contrasting guidelines in different countries exist. ASRA guidelines state that the recommendations regarding Neuraxial techniques should be applied to deep plexus blocks and PNBs. Austrian Society states that distal PNBs such as sciatic or axillary blocks may be performed in an anticoagulated patient. Some researchers suggested that with the advent of ultrasound guidance, these anticoagulated patients can safely undergo blockade of peripheral nerves. Anesthetists should individualize their decision based on the suitability of peripheral nerve blocks in patients on anticoagulants. Discuss in detail the risks and benefits of the block with the patient and the surgeon. If a block is performed, the patient should be observed closely in the perioperative period for signs and symptoms of a peripheral hematoma. To diagnose post-block hematoma, investigations includes CT and ultrasound. Treatment: consult surgical team. Subsequent treatment of hematomas after PNB is typically expected. Treat hemorrhagic shock with fluids and blood products. Surgical drainage is considered only in critical or rapidly deteriorating patients. Next, we move on to how to diagnose and manage patients with neurological deficits after neuraxial nerve blocks. Algorithm for managing neurologic deficits after neuraxial anesthesia. Determine if the neurologic deficit is limited to one unilateral site and attributable to nerve compression at common sites, such as the ulnar nerve in the cubital groove and peroneal nerve at the fibula head. If yes, observe, provide physiotherapy and occupational therapy, pain management, and neurologic follow-up. If no or uncertain, proceed with emergent spine imaging. MRI spine is preferred. Possible pathologies includes epidural hematoma, epidural abscess and acute spinal cord injury. Obtain neurosurgical consultation, correct coagulopathy if present, ID consults and antibiotics as appropriate. Consult neurology and determine whether there is a role for BP augmentation or steroids. The longer it takes to diagnose and treat neuraxial complications, the worse the prognosis. Factors contributing to neuraxial nerve injury includes mechanical damage, for example, direct cord or nerve trauma from the needle or catheter. Mechanical damage is related to structural abnormalities, operator inexperience, and patient movement. Neural ischemia may be caused by systemic hypotension, which may cause watershed ischemia of the spinal cord. Vascular trauma, vascular embolism, increased intraneural pressure, caused by epidural hematoma or abscess, vasoconstriction, which can be caused by vasoconstrictors. If it occurs at the artery of Adam-Kiewicz, this may cause anterior spinal artery syndrome. Severe vasoconstriction can cause watershed ischemia. Chemical toxicity can be caused by local anesthetic, chlorhexidine, alcohol, tranexamic acid, inflammation from infection, ultrasound gel, etc. Spinal epidural hematoma, SEH, is the accumulation of blood in the loose areolar tissue between the vertebra and the dura of the spinal cord. The source of hemorrhage may be venous or arterial. Presentation: 75% present with neurological deficits maximizing over 24 hours, and 25% present with a slower evolution of symptoms. Localized spinal pain at the time of bleeding onset may occur, but anesthesia or analgesics often mask this. The acute axial back pain may radiate to corresponding dermatomes, and the radicular component may mimic disc herniation. The onset of pain is occasionally related to minor strain such as lifting, coughing, sneezing, or Valsalva maneuvers. Back pain is exacerbated by percussion over the spine and maneuvers that increase intraspinal pressure, such as coughing, sneezing, or straining. Sensory loss may be vague and proceed to dense sensory loss below the site of the hematoma. There may be unilateral or bilateral radicular paresthesias. Motor weakness proceeds to flaccid paralysis as sensory loss intensifies, which may be unilateral or bilateral. The patient may develop paraparesis or quadriparesis. Various alterations in deep tendon reflexes are present. 2/3 of patients develop neurogenic bowel and bladder, which can present as urinary or fecal incontinence and alterations in bladder or anal sphincter tone. There may be autonomic dysfunction. Risk factors for SEH includes anticoagulation, antiplatelet usage, thrombolysis, coagulopathy, trauma, lumbar puncture, epidural or spinal anesthesia, technically challenging epidural or spinal anesthesia, interventional spine procedures or surgery, an emergency operation, older age, females, vascular malformation, disc herniation, Paget's disease of the vertebral bones, Valsalva maneuver, hypertension, SLE, ankylosing spondylitis, rheumatoid arthritis, neoplasms, vascular malformations, hemangiomas. Spinal hematoma may occur in the absence of identifiable risk factors. Algorithm for managing a suspected case of spinal epidural hematoma. Epidural hematoma suspected after neuraxial anesthesia, after history and examination. Evaluate the patient, determine the extent of neurological deficit, and review epidural infusion if present, with regards to the type of medication, concentration, dose, and rate. Features for low level of suspicion of SEH includes last epidural dose given less than 3 hours ago, neurologic deficit consistent with neuraxial blockade, presence of sympathetic level, patient not in distress, and there is normal coagulation panel and platelet counts. If there is low level of suspicion, stop the epidural infusion, aspirate the catheter to rule out blood or CSF, and neurological examination every 30 minutes. If there is regression of neurologic deficit, continue evaluation and consider restarting the epidural infusion. If there are no resolution of neurologic deficit, neuro examination every 15 minutes, emergency neurosurgery consult, MRI spine, FBC, and coagulation panel. If MRI spine reveals pathology amenable to surgical intervention, proceed with urgent surgery. If there are no pathology amenable to surgical intervention, consider neurology consult. Features of high level of suspicion includes return of neurologic deficits more than 1 hour after block resolution, last epidural dose given more than 3 hours ago, difficult epidural or spinal, focal neurologic deficit in the absence of a sympathetic level, back pain aggravated by palpation of the procedural site or by Valsalva maneuver, patient in distress, abnormal coagulation profile, and low platelet counts. If there is high level of suspicion, stop the epidural infusion, aspirate the epidural catheter to rule out blood or CSF, and examine neurology every 15 minutes. If there are no improvement or uncertain, proceed with emergency neurosurgical consult, MRI spine, full blood count and coagulation panel. If MRI spine reveals pathology amenable to surgical intervention, proceed with urgent surgery. If not, consider neurology consult. Differential diagnosis for suspected epidural hematoma includes epidural abscess, spinal cord disease, neoplasm, acute disc herniation, surgical neuropraxia, prolonged or exaggerated neuraxial block, anterior spinal artery syndrome, exacerbation of a pre-existing neurologic disorder, and presentation of a previously undiagnosed neurologic condition. Important investigations to consider for SEH includes MRI spine, CT spine, full blood count, coagulation profile, angiography, and myelography. MRI spine versus CT spine. Any concern for spinal cord dysfunction after neuraxial anesthesia requires emergent neuroimaging. MRI spine is preferred because it is able to assess the extent of the hematoma and its age. It is better at localizing catheters, differentiating soft tissue structures, defining impingement of adjacent structures such as the spinal cord or nerve roots, identify pre-existing comorbidities such as spinal stenosis. MRI spine is able to identify vascular malformations and is non-invasive, unlike myelography. If MRI is not immediately available, CT spine should be pursued. CT spine is acceptable as initial imaging to exclude a compressive lesion. Imaging should not be delayed to arrange for an MRI spine or to obtain neurologic consultation. If CT is negative without resolving neurologic deficits, MRI spine should be arranged to assess for an intrinsic cord pathology as soon as possible. CT spine is able to identify space-occupying lesions such as hematomas and abscesses that require emergent neurosurgical intervention. However, CT spine may give false negative results if the hematoma is isodense to the thecal sac or spinal cord. Image quality is affected by artifacts often seen in the upper thoracic region. CT spine may be non-diagnostic in the thoracic spine, where resolution is poorer than in the lumbar or cervical spine. CT spine lacks the soft tissue discriminatory sensitivity of MRI and is unable to identify an intrinsic spinal cord injury, such as anterior spinal artery syndrome or due to direct needle trauma. Full blood count. The degree of reduction in Hb or hematocrit may indicate the extent of bleeding. Increased total white counts may indicate infection. Thrombocytopenia is a risk factor for bleeding. Coagulation profile to determine the presence of bleeding diathesis and whether correction is required. Conventional angiography may be required to definitively demonstrate the presence of a vascular malformation. Myelography has been replaced by MRI spine as the gold standard for diagnosing epidural hematoma, as findings for myelography are not specific. Myelography is invasive and may worsen the patient's clinical status and can't determine the nature and true extent of the lesion. Treatment. Urgent surgical decompression of epidural hematomas is the treatment of choice for SEH causing acute compromise of cord function. The goal should be surgical evacuation ASAP after the diagnosis, as the severity and duration of neurologic deficit at the time of evacuation predicts outcome. Severe deficits at evacuation results in lower likelihood of a good recovery. If the evacuation of SEH occurs within 8 to 12 hours of presentation, 40 to 66% of patients make a complete recovery. If the evacuation of SEH occurs more than 12 hours after the presentation, more than 50% experience no neurologic improvement or severe residual neurologic deficits. Overall mortality rate is 8%. Surgical consultation for consideration of emergent decompressive laminectomy must be obtained ASAP, and the surgical team must decide to observe or operate on a case-by-case basis. Recovery can be achieved when surgery is performed within 48 hours of an incomplete motor deficit and within 36 hours of a complete motor deficit. Functional recovery after 72 hours of symptoms has been reported. Case reports have described successful conservative management of epidural hematoma with good outcomes reported for hematomas localized at the cauda equina level and those with mild neurologic deficit, and in patients reporting back pain and leg weakness or numbness but does not exhibit leg paralysis. Conservative measures include reversal of clotting abnormalities, close observation of neurologic deficits, and steroid administration. Prevention. Neuraxial anesthesia should be avoided in patients who are on anticoagulant therapy, have received thrombolytic therapy, or are suspected to have a bleeding diathesis. The decision to perform neuraxial blockade and the timing of catheter removal in a patient receiving antithrombotic therapy should be made on an individual basis based on the guidelines published by ASRA, NYSORA, or European and Scandinavian Society of Anaesthesiologists. Weigh the risk of spinal hematoma with the benefits of regional anesthesia for a specific patient. Spinal or epidural abscess in the setting of neuraxial anesthesia. Presentation. The patient may present with localized spinal pain, but analgesia or anesthesia often masks this. Fever, spinal nerve root irritation in a distinct radicular pain pattern, sensory loss below the site of the abscess, motor weakness progressing to flaccid lower extremity paralysis below the level of the abscess, neurogenic bowel or bladder, meningitis, elevated serologic inflammatory markers, and positive cultures. Risk factors include diabetes mellitus, immunosuppression, cancer, pre-existing infection, IV drug abuse, alcoholism, trauma, and prolonged duration of epidural catheter. Prognosis. Functional recovery is good if treated definitively before paralysis or in those with paralysis lasting less than 36 hours. Functional recovery is poor if paralysis lasts more than 48 hours. Overall, 1/3 remains paralyzed and 15% of patients die. Diagnosis and treatment. Based on the ASA Practice Advisory for the Prevention, Diagnosis and Management of Infectious Complications Associated with Neuraxial Techniques recommendations, daily evaluation of patients with indwelling catheters for early signs and symptoms of infectious complications should be performed throughout the patient's stay in the facility. To minimize the impact of an infectious complication, promptly attend to signs or symptoms. If an infection is suspected, remove an in situ catheter and consider culturing the catheter tip. Order appropriate blood tests and cultures. If an abscess is suspected or neurologic dysfunction is present, imaging studies should be performed and consultation with other appropriate specialties should be promptly obtained. Appropriate antibiotic therapy should always be administered at the earliest sign or symptom of a serious neuraxial infection. Consult a physician with expertise in the diagnosis and treatment of infectious diseases. If an abscess is present, obtain surgical consultation to determine whether percutaneous drainage of the abscess or surgery, such as laminectomy, is warranted. Anterior spinal artery syndrome in the setting of neuraxial anesthesia. Etiology. There is reduced blood supply to the spinal cord from the anterior spinal artery, causing ischemia to the anterior 2/3 of the spinal cord. Reduced blood supply to the spinal cord from the anterior spinal artery may be caused by embolization, for example by steroids, vertebroplasty cement, and atherosclerotic debris, dissection, vasospasm, and direct trauma to the artery of Adamkiewicz in the thoracolumbar spine, or direct trauma to vertebral, ascending or deep cervical arteries in the cervical spine. Examples of inciting events include neuraxial pain interventions such as transforaminal epidural steroid injections, paravertebral procedures, and neuraxial anesthetic procedures during which the needle is placed laterally in the interlaminar space. The presentation is fulminant and acute. The patient may present with para or tetraplegia. Sensory level is limited to pain and temperature modalities, with relative sparing of proprioception. Tone and reflexes. Spinal shock causes initial areflexia and a flaccid tone. Hyperreflexia and spasticity occurs at a later period. Treatment and prognosis. Consultations include neurologist, neurosurgeon, and neurorehabilitation specialists. No treatment has been proven to improve neurological outcomes. Standard measures for management of complications of acute paraplegia, such as pulsatile leg wraps, low-dose heparin, physiotherapy, and mobility devices. 2/3 do not improve, minimally improve, or die. Those that survive often require gait aids, wheelchairs, and have neurogenic bowel and bladder dysfunction. Spinal cord and nerve trauma in the setting of neuraxial anesthesia. Direct needle trauma to the spinal cord with neuraxial anesthesia is difficult to recognize, as needle insertion into the cord without injection may not cause pain. LA injection into the spinal cord may cause pain due to increased intramedullary pressure, but this pain may not be obvious in a sedated patient. The presence of paresthesias alone does not indicate cord trauma. Paresthesias are not uncommon in properly performed epidural anesthetics. Spinal cord trauma is most common in cervical spine procedures. It is commonly associated with major morbidity or mortality. Clinical manifestations and prognosis of direct needle trauma to the cord is variable and depends on the site of injury and whether an injection was performed. No treatment exists that has been proven to improve neurologic outcomes. Evidence is insufficient to recommend corticosteroids in the treatment of acute spinal cord injury. How to prevent infections associated with central neuraxial blockade. Microorganisms gain access to the subarachnoid, epidural, or tissue space surrounding peripheral nerves to cause infection after central neuraxial blockade via several routes: direct inoculation, hematogenous spread, migration along the catheter tract, injection of anesthetic agents contaminated with microorganisms, and equipment used for nerve block contaminated with microorganisms. Skin preparation with alcoholic chlorhexidine versus povidone iodine. Regarding the effectiveness for skin antisepsis prior to neuraxial blocks, no studies were large enough to assess rates of infection, and outcomes evaluated in studies were catheter or skin colonization. More studies have demonstrated that alcoholic chlorhexidine is superior than povidone iodine in skin antisepsis, compared to those that suggest otherwise. Risk of neurotoxicity. An experimental study by Doan and co-workers found damage to neuronal cells with chlorhexidine as well as 10% iodine. A relevant toxic concentration of skin disinfectants cannot be reached if the puncture is performed through dry skin. Allowing the skin to completely dry once disinfected before performing the block is more important than the choice of the solution in order to prevent neurotoxic effects. Several authorities concluded that chlorhexidine in alcohol should still be used as the potential for neurotoxicity was outweighed by the superiority in reducing surgical site infection. Experiences from the Mayo Clinic analyzing almost 12,000 spinal anesthetics that used alcoholic chlorhexidine did not observe any change in neurological complications. Summary of recommendations of infection control practices for nerve blocks. For single-shot peripheral nerve block, hair cover, mask, sterile gloves, chlorhexidine in alcohol skin prep, sterile drape, and sterile ultrasound probe cover and gel are recommended. For continuous catheter peripheral nerve block, preparation of injection or infusion solution under sterile conditions, hair cover, mask, sterile gown, sterile gloves, chlorhexidine in alcohol skin prep, sterile drape, sterile ultrasound probe cover and gel, tunneling of catheter, and filter on injection or infusion system are recommended. For single-shot Neuraxial block, hair cover, mask, sterile gloves, chlorhexidine in alcohol skin prep, sterile drape, and sterile ultrasound probe cover and gel, if used, are recommended. The recommendations for continuous Neuraxial catheter is the same as those in continuous catheter peripheral nerve block. For long-term implanted device or catheter, prophylactic antibiotics, special procedure room, hair cover, mask, sterile gown, sterile gloves, chlorhexidine in alcohol skin prep, sterile drape, and sterile ultrasound probe cover and gel are recommended. AAGBI Safety Guideline Skin Antisepsis for Central Neuraxial Blockade 2014. Recommendations includes optimum aseptic technique for CNB requires thorough hand washing with surgical scrub solution and the use of barrier precautions, including the wearing of a cap, mask, sterile gown and gloves, and the use of a large sterile drape. Chlorhexidine in alcohol should be used for skin antisepsis before performing central neuraxial block. The anesthetist must be meticulous in taking measures to prevent chlorhexidine from reaching the CSF. Chlorhexidine should be kept well away from the drugs and equipment to be used for neuraxial block and should not be poured into containers on or near the same surface as the equipment for neuraxial block. Equipment should be covered or protected while the antiseptic is applied by the swab, applicator or spray. The solution must be allowed to dry before the skin is palpated or punctured. The operator should check his or her glove for contamination with chlorhexidine. If there is any doubt, they should change before continuing with the procedure. Given the lack of convincing evidence of the antimicrobial superiority of a 2% solution of chlorhexidine in alcohol over a 0.5% solution, but the presence of clear evidence of the neurotoxicity of chlorhexidine, the working party has concluded that the use of a 0.5% solution should be preferred over a 2% solution for skin antisepsis before neuraxial block. In children under 2 months of age, the volume of chlorhexidine used should be the minimum necessary while still ensuring antisepsis. For completion purposes, the ASA 2017 guidelines for the placement of neuraxial blocks recommendations are included here. These are my references. Thank you.